It's recording.
All righty. Hi, everyone. My name is Elana Frank. I'm the CEO and founder of Jewish Fertility Foundation. I am so excited to be here today with Dr. Michael Werner, the founder and medical director of Male Sexual and Reproductive Health. Dr. Werner is a renowned authority specializing in the diagnosis and treatment of male sexual dysfunction and male infertility. So our community submitted a bunch of questions prior to this Zoom today, and I'm going to be asking Dr. Werner the top questions that you asked. So let's just jump right in. Let's start with an overview of fertility. Can you give us an overview of what male infertility might look like?
So when I'm thinking about it, I'm always really looking at the couple. And the way I think of it is, let's say that it takes 100 points to conceive. So some points come from the man and some points come from the woman. If they're usually in my office, then they have not easily achieved those 100 points.
Right.
And usually the criterion are that it's been a year of trying for a couple. And if the woman's over 35, then we usually use 6 months. So what I tell them is that there's really 3 ways of getting points. So one is to see what's going on with the man, and that's my job. So my job is to basically establish a baseline for his semen analysis, because there can be variability. Secondly, see if there's anything medical that could be affecting his health that's going on. And then of course 3, see if there's anything I can do to improve it. The second way is to do the exact same, but with the reproductive endocrinologist, doing that with the woman, seeing if there's anything reversible. She's not ovulating. Does she have a fibroid in the uterus? And then once we've maximized, it's best to maximize those points, because then you bring those points into every cycle that you try to conceive. And then the third way, if those aren't enough or we don't find anything, is to try to get her more fertile in any given cycle. And the principles are to try to get her to make more eggs and to get his sperm closer to the eggs. So there's inseminations and there's in vitro fertilization.
Okay, so pretend that I'm a woman, right? And
I think you are a woman. I don't have to pretend, yes.
So I know that when my husband and I were going through our infertility journey, he happens, I'm very open, but he happens to be very private. And I wasn't with him when he was having his sperm analyzed. What actually happens when you're obviously you're going to be using a microscope, but what happens? What does the man have to do in order for you to
do a semen? So a lot of the men are very recalcitrant about doing a semen analysis. Historically, people always just blamed the woman if there was a problem. And they would have, when I started my practice, so that's 27 years ago, basically the woman would have her full evaluation before they dragged the man in to have a specimen. And that is not the case anymore. I'm finding that it's sort of, the OBGYNs are like, the first thing they do is like, okay, you go get a specimen. And so we have a lab and we see, more than 2,000, we do more than 2,000 semen analyses a year, some of which are screening. But in terms of the production, the men are getting better and better at this. And so they just know that it's their job. So they're supposed to abstain for 2, 3, or 4 days. So 2 to 4 days, meaning no masturbation, no intercourse, no ejaculation of any kind. Then most of the vast majority of the men will then come into our offices to produce the specimen. And they have their own room and, a lock on the door and a lubricant, and they can use their phone if they want, or a video for pornography, and they produce the specimen, obviously in private. They get dressed, they ring the buzzer, and we do the semen analysis.
Does it have any, we get these questions a lot of times from the women, does it matter if they are requesting to do it at home? Is it a difference for you?
Yeah, so it's a good question. So we do have men who are much more comfortable at home. And so you just want to make sure that it stays at body temperature. So we don't want it in the freezer or on the radiator. Easiest thing to do is just tuck it into an internal shirt pocket and put on a jacket. And we'd like to get it within an hour. Because what happens is, ironically, the fluid that a man ejaculates the sperm into, in the semen, is actually not good for sperm. What happens when a man ejaculates is it goes into the vagina, obviously. The sperm are released into the cervix, And the fluid that they actually like is the fluid that's found in the woman's reproductive tract, specifically in the tubules, which is where fertilization, the fallopian tubes, which is where fertilization takes place.
All right, well, thanks for that. Talk to us about extended sperm search and microfreeze.
Got it. So one of the things that we see with men that can be very frustrating for the couple is that a man has what we call cryptospermia, meaning occasionally you see one sperm, occasionally you don't. Even when you spin it down, you see one or two, but obviously that's not usually, it's not predictable. They don't always have something. And the day of an in vitro fertilization cycle, you may not find anything. So the Israelis actually came up with this technology. It was very cool. And we're actually, for some reason, the only people who've brought it to the States. And what you do is you spin it down, but then you take 6 or 8 hours to look through it in microdroplets. And that's the first part. That's the extended sperm search. But then, what happens if you find them? What do you do with them? But then they came up with a way of putting them into microdroplets on a specialized slide and freezing them in a special way that they actually are easy to find and have a high recovery rate. So with men who have like no sperm, cryptospermia, very, very few, we have almost 100% chance of finding enough sperm for them to then proceed with an IVF without having to do a testicular sperm extraction.
So now we have clients all over, America. What happens if some of our clients don't know that this procedure exists?
Well, yeah.
Is that even, can they come to you?
Yes. So the interesting thing is because the sperm can be frozen. I mean, I think we are the first ones in the United States, but I'm hoping that it spreads because in general, I care more about the fertility than having it all done in my office. But this is one of the technologies that can absolutely, and we have people coming from all over the country to us to do this. And then since we've frozen it, we can send it back with them. Locally, we've actually been doing some of them fresh and just sending them on these little slides, the fresh sperm, which was really fun.
Can people, I'm in Atlanta right now, can I send my sperm to you in FedEx and you take care of it, or it has to be done?
No, they have to come and produce a specimen here.
Interesting. And then you can ship it back.
Then we can ship it back. Yeah, or whatever.
Interesting.
Yeah.
Interesting.
The other thing that we do is for the men who have asospermia, which means they have no sperm in the ejaculate, we can also do the ESSM, and about 40% of those men, 44% to be precise, will actually have low numbers of sperm that we can freeze, and that prevents us from having to go in and doing an invasive biopsy to get the sperm.
Tell me more about that. What happens if this doesn't work for them? What is the more invasive procedure?
Right, so working backwards. So if we talk about men with asospermia. So asospermia means that you don't have any sperm in the ejaculate. And of course, if you do a sophisticated semen analysis, you should wash it down. You should spin it down and then look for it there. But let's say you still don't have anything. You do your evaluation to make sure there's nothing genetic going on. Is there anything you can do hormonally to reverse it? But if you're still, we don't have an answer or there's nothing we can do to reverse it, then the next step can be the ESSM, where basically you abstain. It's a pain in the neck. You abstain for 10 days, and then you spin it down and look. And sometimes we find the sperm, and those can be used for an IVF. If you don't find sperm in that, you have two choices. One is a sperm mapping, where you can do in the office in a non-invasive or relatively not invasive procedure where you put a bunch of needles in the testis. It sounds terrible, but actually we've had guys sleep right through it. And you sort of map where the little locations for the sperm would be. If you don't find anything there, or you can skip that step and go right to a microscopic testicular sperm extraction, where you go in and you look for sperm in individual tubules. Usually that's combined with an in vitro fertilization, so they can take those sperm and inject them directly into the eggs.
Now, are they sleeping during this? Or are they awake?
So yes, depends on the procedure. So the sperm mapping, no. The testicular sperm extraction is done in an ambulatory care center with an anesthesiologist, so they are sleeping through that.
Got it. Wow, that's pretty interesting.
It's pretty amazing.
We're missing about ESSM. How'd you find out about it?
So actually what was interesting is one of the infertility groups that serve the ultra-Orthodox called A-Time had been doing it on their patients in Israel. They've been flying the patients to Israel, and they asked us if we could start it here. And I was like, yeah, this is brilliant, and I should have come up with it myself, but they were very helpful. So that's how it came to us. It was sort of interesting, actually.
Amazing. Are you training anybody else right now?
So no one's asked. We have two of our, we have two people in our lab who do it, but the Israelis will train whoever. And they've been training people in India and a bunch of different countries in the world. So it is spreading, and I think it will become the standard of care.
Amazing. Well, thanks. Let's talk about, I'm going to say this wrong. What is the lack of sperm?
Asospermia. Yeah. So
Asospermia. How is it diagnosed?
So again, that's when you have no sperm in the ejaculate. So the first thing to do is the semen analysis, and if when you spin it down, there's no sperm, then that's the diagnosis of asospermia. And then again, what we're trying to do is see if we can, just because a man comes in with that does not mean that we're not going to find sperm anywhere. And whenever I think about asospermia, the way I break it down is, is it a production problem? Is the man having a problem making sperm, so he makes very few or not any? Or is it a problem with delivery? Is he making them but can't get them out? There's a very interesting condition called congenital bilateral absence of the vas deferens, CBAVD, where it's almost like men are born with a vasectomy. Like they have the testes and sometimes the drainage tubes, but they don't have the vas deferens, which is the tube that carries the sperm. And those are always a fun diagnosis to make, because almost always they're making sperm, they just can't get out. So those couples, or if they're willing to do in vitro fertilization and go in and get the sperm, have a very high chance of having sperm, and then depending on the woman's age and fertility, success. So there can be obstruction, or there can be a production, and so then we're trying to figure out which one there is, and then treat or get sperm from whatever we find.
I have 3 boys, so I'm always thinking, they're young and they like to have conversations about their bodies, and it's something that as a mom I think about. We're not going to know if everything is okay until they get to the point of trying to have a baby, right? You can't find out.
Well, it's a good question, but it's interesting. The pediatricians usually will do a genital exam. They want to make sure that the testes have both come down, and they're actually the ones who will often send me the patients with the adolescents with varicoceles, which are dilated veins in the scrotum. So, there is a definite relationship between testicular size and sperm production, but I'm not sure that you would necessarily want to find out there was a problem unless there's something you can do about it early. Varicoceles are something that you can do something about early.
So what's the exact best way to fix it, a varicocele?
So a varicocele is basically, it's the most common potentially reversible cause of male infertility. So 15% of all men do have varicoceles, and 40% of men who have subfertility have varicoceles. So, and basically what it is dilated veins in the scrotum. So the way people think about it is, you've seen people with varicose veins in their legs, often women who've had children, it's basically, the problem is that the valves that are bringing the blood back up to the heart are not working. So the blood collects in the lowest area. That's a varicocele. And when it's happening in the scrotum, and we know that it has a negative effect on the testis and on sperm production. The theory is by warming up the testis. So that's what I was saying, that the pediatricians will sometimes pick up in adolescents. So if we fix it, then 2/3 of the men will have an improvement in their sperm quality, but 1/3 of them won't. So it doesn't always help.
And so what's the best way to fix it?
So there is a gold standard way to fix it, which is called, it's a mouthful, of microscopic, which means we're looking under the microscope, subinguinal, which means you go right below where the inguinal canal is, where you have a hernia. So right basically where the pubic hair is 1 inch above and 1 inch over. You make a small incision, you pull up on the blood vessels, and then you're actually looking through an operating microscope and tying off the veins, And what that does is it stops the blood from going backwards. And then people ask, well, where does the blood go? It finds other routes. Just like with people with varicose veins in their legs, they strip out the superficial ones and the deep ones take over.
How successful is the treatment?
Well, the surgery itself is very good at getting rid of the varicocele. And 2/3 of the time, you'll see an improvement in the sperm production. But just remember that the sperm that a man is ejaculating now the sperm started dividing 2 or 3 months ago, really 3 months ago. So you won't see any improvement when you do anything until 4 or 6 months. So it doesn't stop things, it doesn't put you on hold, you just won't see those improvements.
And what is the procedure actually? Is this a sleeping one? Is this
Yeah, so it's done as a local in the hospital, because you need the microscope and the anesthesiologist, but local with sedation. So the way I do it, 98% of the men are sleeping but not intubated. So it's sort of nice. And it's done as an outpatient. I do them on Fridays, and when people, were going to work, before COVID, then we would find that most of them were going to work by Monday.
And what's the pain level like afterwards?
It's really everyone has different pain thresholds. So you have, like, I'm terrible at pain, so it's always worse than they tell me it's going to be. But, it's much less than a hernia. They're not moaning around that weekend. Sometimes I call them afterwards and they're on the golf course and I'm yelling at them, get off the golf course, because I don't want them to cause bleeding or anything like that. But it's not terrible. It's really it's much less than your typical surgery.
Okay, talk to me. You talked a little bit about how long it takes sperm to kind of change. We get questions a lot around, like, should my husband be taking vitamins? Should he be taking supplements before we're trying to have a child or before we do a fertility procedure? Do you have any thoughts about that in general, and then what they could be doing?
Yeah, so I'm not a big supplement person, because I'm sort of like, I like things to be proven rather than, so I do think it's a great idea, and just in general, to take a multivitamin, though if you look at big studies, there's really no evidence that helps in health. It's just that most people don't really have, great and varied diets, so that makes sense to me. And most people are deficient in vitamin D, and so why not? And then the only thing I've ever seen any proof that is useful are the antioxidants. So the company that I think has the best product is called Theralogics. Therologix, Theralogics. And so you just go on to theralogics.com. They have 2 main products. The one that I usually have people use is the cheaper one, not the motility blend, which has an expensive ingredient that I don't think is proven, but just the general, fertility support one. I think it's like $30 a month, and you would probably get 3 to 6 months worth. So I think that could be useful, especially if we see like white blood cells in the semen analysis.
All right, helpful. All right, testosterone and male infertility. Talk to me.
Right. So the first thing is that, interestingly, if you take testosterone from the outside, that will usually shut down or certainly decrease dramatically the sperm that a man's made.
I've heard it's like a male's birth control.
Yes, it's the worst of both worlds, though, because it definitely impedes fertility, but it doesn't cut it out completely. So you can't rely on it as birth control. So it's and what happens is, the reason is that in order to make sperm, the testosterone that a man has to be made in the testis itself. The testis needs a very high concentration of testosterone in order to make sperm. So if you give testosterone from the outside, it shuts down your own production of sperm, and then that decreases the production, it decreases the testicular production of testosterone. And if that means that you don't achieve a high level of testosterone in the testis, which means that you shut down or certainly, decrease the production of sperm. We can give men with low testosterone levels medications, specifically clomiphene citrate, Clomid, or HCG, which then push the testes to make more testosterone. And that can sometimes improve the sperm production and make them feel better as well. But I do get a lot of men who have been on testosterone, either self-prescribed or by their doctors, who were not aware of the fact that it shut down sperm production. And then we have to get them off of it. And sometimes they're not very happy as they're coming off of it. But we try to give them the other medications that will make them make their own testosterone, so at least they don't bottom out their testosterone when they're coming off the testosterone.
That's a lot. Huh. And when should people be getting testosterone? Like when is I know that many men have low testosterone symptoms, or they think they do, or their doctor tells them. At what point in their life should they be
on testosterone?
Testosterone.
Yeah, so I'm a great believer in testosterone. And so, but basically you're not treating the number, you're treating the patient. So if a patient comes in, let's assume that they're finished with fertility, so we don't have to deal with sperm production, right? Okay. So you get a 45-year-old man who comes in and has symptoms of a low testosterone. The symptoms,
like what?
Yeah, so the classic symptoms are decreased energy. For me, if a man in his 40s or even 30s or 20s is taking a nap in the middle of the afternoon on a work day, we have a problem. Okay, so decreased energy, decreased libido. So so he still loves his partner, but and finds him or her attractive, but just doesn't want to have sex with anyone. That's a very good sign. It can have a modest effect on erections, but that's not necessarily. And it can be difficult to take off fat, put on muscle, get themselves to work out. And also they can sort of have a brain fog where they're just not as sharp. Working backwards, if they have a low testosterone and they have a significant number of symptoms, and we put them on testosterone, 90% of the men will feel dramatically better. And so that's nice.
That's amazing. And what are some of the methods that we use for testosterone?
Right. So just to backtrack a little bit, so I am more aggressive than most people. So to me, if normal range is 300 or below, I'm not trying to get them to 320. I'm actually trying to get them to 600, 700, 800, which is when they feel better. And also, it can take a while before they feel better. So I sort of have a verbal contract with men. It's like, we have to do this for a year before you decide whether or not you've had an improvement. Usually it does not take that long, but I tell them it takes 3 or 4 months to notice energy, 6 months to notice a change in erections, and up to 9 months to notice the change in libido. Wow. So I get a lot of men who've come in, they've had a low testosterone, their doctors give them a low dose of the topical for a month, they don't feel better. Their numbers went from 220 to 370, and they say, well, this doesn't work for me. And that, of course, in my mind, is not a real trial. Back to your question about what the options are for treatment, there's a lot of them. There are topicals, which you can put on every day. You want to make sure that those don't get on your partner if she's a woman, and on your kids, and especially if she's pregnant. I find actually a lot of the men start with that, but then don't like it. They don't get good absorption, or it's annoying for them. There's one that, I can go, there's literally about 10 different ways.
Oh, wow. Okay.
Most of the time it boils down, the two that I like the best are once a week, they can give themselves an injection. It used to be thought that they had to give it in the muscle, but actually you can give it in the fat, believe it or not, which is sort of cool and less invasive. And the second one that we use, which is bioidentical, are we put in pellets, these little, they look like a grain of rice, in the skin above the tush once every 3 months. And that works quite well.
Wow.
Yeah, it's fun.
The things we do for our bodies.
Well, the men feel dramatically. It's a game changer for the men and for their partners, because. Well,
I know it's just not only about about sex. I think it's also about just feeling blah. So I think that's really helpful. Amazing. All right. Well, Dr. Werner, thank you so much for your time. Is there anything else you would like to leave our community with? Any wise words?
The only thing I would say is we do get men coming in all the time with really terrible semen analyses. So
Mhm.
one of the things that, again, no one can guarantee people a baby, but I would say that in my experience, if the age of the woman is good and the man has any sperm
Mhm.
and they are proactive, the vast majority of couples do conceive using, their gametes. So it's as distressing, people are really on the floor when they come in with these terrible semen analyses. And I don't want to be a Pollyanna, and we can't guarantee anyone a baby.
Right.
But the vast majority of people do end up successful. The key is, again, once you want to have children, don't, do it sooner rather than later.
Yep.
I'm in the, like the younger the better, as long as you know it's the right partner, because you have a better chance of conceiving more easily. It's healthier, and what are we waiting for exactly? So.
Yeah, well, that's reassuring. Thank you so much for your time. This was fun.
My pleasure. Thank you so
Talking
much
about
for
this can
having me.
be.
Okay.
Thank you so much.
Take care.